Well, Teresa, that was a nice introduction for our next speaker, Dr. Shroff, and he's a cardiologist, and he's going to talk to us about FFR. And I suppose for many of us, we kind of think along the lines that there is a connection between competitive flow and the findings in FFR. And I see Dr. Blackstone out in the audience, and Gene has taught, if he's taught me anything in 15 years now, he might tell you that I'm hard to teach. But there are no really, it's always nice to dichotomize the linear variables, but it's always a bad thing, and it's always a continuum. And that and so as we think about competitive flow and FFR, I think one of the messages that I'm taking away is that all competitive flow is not the same. Some is important and some is not important. Now we're going to hear about FFR and the effects, I imagine, on FFR and stenting and what we've learned in FAME. But now, how can FFR help us in coronary artery bypass surgery? Dr. Shah.
Well, thank you for inviting me here today. This is a very unusual talk for me, giving a talk to a bunch of cardiac surgeons. But I'm excited. I think when Howie invited me, I thought about it, and I said, well, this is actually, when I think about it, these are really just two ways to look at the same problem. And I think we're all in the same boat together when we see these patients. I mean, we see them and then we send them to you. And then when they come back to me in a year or 8 months later and I look at them and their lima is occluded or atretic, I sort of feel like, as a community, we've sort of failed this patient. They've undergone this huge surgery, and the thing that's actually life-saving for them is not working. And I always think that, what could I have done differently? And I think incorporating more use of FFR, I think, would be helpful. And I'll sort of share my experience with that. I think part of this talk was actually a discovery for me of looking into this space a little more and figuring out exactly what is this issue of competitive flow. And so some of this may be review for a lot of the people in the audience, and I apologize for that. So my disclosures are I'm getting an honorarium for this talk, and I also consult, and I teach a course on FFR at my university for other cardiologists, practicing cardiologists. For that, I get a grant from St. Jude. So what I'm going to talk to you about in the next 15 to 20 minutes, I'll just do a brief case presentation to kind of set a context for all of you, and then give you a brief overview of FFR, talk a little bit about the technology for those of you who are not maybe as familiar with FFR. I'll review some of the clinical data, or at least the landmark clinical data, and then guidelines, sort of what you need to know about FFR. And then I'll talk about what little literature there is about using FFR in CABG patients to assess graft stenosis, even though I know no one's grafts ever stenose. And then finally, looking at FFR prior to CABG to assess competitive flow. And I think that's something we've been talking a lot about in our community, of whether we should start doing this more routinely prior to sending people to bypass, to help give you guys some more information. I think this is what Howie and I was talking about a little bit, that I think some of this is on us, that we used to send these patients to you and we say, here, fix all these vessels, and you guys are doing that. But I think sometimes we need to give you some more information, and now that there's actually more information available, I think this is something we can sort of offer as a service to you. And so this is a 50-year-old gentleman with a history of coronary disease who's had 2 stents in the RCA in the past, and he comes to clinic complaining of chest pressure for the past 2 months. The pain lasts for 10 minutes, gets better with nitro. So a very classic story for angina. He had some shortness of breath, nausea, lightheadedness, and then he ran out of his aspirin and was told to start this as well as a different beta blocker. And then he got referred for a coronary angiogram. And so you can see right here on his anatomy, you can see relatively quickly here, there's at least something going on here in his distal left main. And this is what I think as cardiologists we've all admitted now, for at least, I think we're all free to admit for at least the last 15 to 20 years, that we're really good when the lesions are 70, 80, 90%, and we're really good when they're 30, 20, and 10%. But when they're anywhere between 30 and 70%, we have been shown over and over again in trial after trial that we are not that good at assessing how tight these lesions are. And if we're not that good at it, I'm sure you guys are probably not that good at it either from an angiogram. And so that's kind of where this whole space is kind of developed in the interventional cardiology land. And so really, FFR is an intermediate lesion assessment tool, and there are several different tools that are available now in the market. And there's, you can break them down really into 2 large categories. There's anatomic ways to assess intermediate lesions, and there's a functional-based ways to do that. And you can sort of divide all the imaging modalities into those 2 buckets. And IVUS, intravascular ultrasound, is probably the I guess the landmark or the hallmark gold standard for anatomic visualization or assessment of a lesion. And it's an ultrasound-based technology that works over a catheter. Where we get very nice images. It's been around for a long time, so there's lots of data, lots of outcome data on it. The problem is that you get really no functional information. So the sort of the talk is, if you want to stent someone, do IVUS. If you want not to stent someone, do FFR. And so I think that was always the thing. So we always sort of realized that there was some limitation to this. And then there's a lot of subjective interpretation. Like looking at this type of image it's sort of like watching black and white TV and trying to figure out what exactly is going on. And I think there's a lot of people who didn't train with IVUS like myself, and it was always very difficult for me to make very important decisions like whether to send someone to surgery or not, based on something that I wasn't very confident with. And so there is a newer technology called OCT, or optical coherence tomography, which is very similar anatomic assessment, but it's a light-based technology. And for those of you who've seen it in the cath lab, it's like, again, black and white TV versus an HD television. And so these are really nice images if any of you have ever seen those. And then again, IVUS has a very nice literature in terms of where it stands in terms of practice guidelines. It is sort of as a 2 indication for a variety of different indications. And so people, IVUS again is part of our landmark, or part of our basic toolkit as interventional cardiologists. And you can see here 2 of the main reasons that we do it is to assess indeterminate left mains and to assess other indeterminate lesions. So it's exactly for this type of indication. And so FFR, or fractional flow reserve, is really is probably one of the few, or probably the only functional assessments available of physiology, of coronary physiology, to actually determine lesion severity. And what it works basically on a concept of measuring translesion pressure gradients. What it works is there's a 014 wire right here that has a pressure gradient, a pressure transducer at the back of it that looks just like that. And then what you'll do is, I'll show you in a second what exactly happens. It's well established correlation to clinical outcomes, as we've heard already, but from FAME 1 and 2, which I'll review in a few minutes. So again, it's well established, validated tool. Volcano and St. Jude are the current producers, so there are 2 different companies that make this, who have this technology. And so basically what works is you have a proximal pressure transducer, which is the tip of your guide catheter, your diagnostic catheter, and then you have this distal transducer, which is at the end of the wire. And then typically all you're doing is you're looking at the distal coronary pressure and you divide it by the proximal coronary pressure. And really the cutoff, for those of you who are not aware, is the FFR is less than 0.8 is considered a flow-limiting lesion. And here's what the image looks like and what you get. And it's a very nice image. You can see it very clearly. You can see that the images sort of start off, and then as you give the drug, the vasodilator drug, you can see the curves separate. And it's actually a very nice modality. You can pull back the wire to see if you have serial lesions. Sometimes you can tell what lesion is contributing more to the stenosis. And here again is the concept. You have a sort of pressure in the sort of proximal pressure and a distal pressure, and you can see right here what we're looking at is a translesion gradient. Here's the capillary bed, and then here's the venous side. And I show this slide primarily because FFR does have some limitations if you're applying it to a post-cardiac surgery patient, in that when we do FFR in the lab with patients with native coronary disease and looking at native lesions, what we do is we assume that this whole system, the capillaries and the venous side, is all 0, and we give drug to do that. And in the post-bypass patient, I'll highlight some of the reasons, that this assumption may not always be correct. And so in all the trials of FFR, it was really all native coronary disease patients and really not any bypass patients that were included in those trials. And again, now going back to our patient here with this intermediate lesion, and so what we did for this person was we actually did FFR, and here's that tracing. I apologize that the video didn't come out from my phone that well, and I'll show you but anyway, what you can see in real time, within 2 or 3 minutes, you can see the gradient develop between this red and this green, and then right here is sort of what the still shot looked like, and 0.76, and so that's considered a significant lesion, less than 0.8, and so that was significant, so the patient went on for cardiac surgery. And so now, in terms of the FAME trial, that was probably the second trial, the modern trial. And so what happened is a group of patients were randomized after having a lesion that was felt to be needing intervention. And so what they did was those patients only underwent angioplasty if the FFR was less than 0.8. And then what they did in the other group was that they said, okay, for the other, if you randomize the other group, if the doctor felt that it was tight, they would go ahead and fix the blockage. So angiographic guided angioplasty. So FFR guided versus angiography guided. And so this is sort of the usual care, and this was the novelty or the new thing, was letting FFR determine whether you go ahead and fix the blockage or not. And you can imagine this is quite controversial for a lot of the interventionalists because it was hard to walk away from lesions that people were very confident were tight, and you're walking away from this and saying, oh, we're not going to fix this. But I think I really have to credit the authors and the investigators for sticking with the science and actually trying to show what they were trying to show. And what they found here, and you can see at 30 days, 90 days, and 180 days, all up to 360, and actually out to 1 year, you could see a steady sort of, I guess, a lesser accrual of events in the patients who had FFR-guided PCI. So again, the people who had FFR that determined that was less than 0.8 got interventions. And if you had that as your strategy, you had better outcomes. And if you look at exactly what were the differences, it wasn't that they were dying less or having less heart attacks. What happened was that they were having less peri-procedural events and less repeat revascularizations in that FFR group. And so this was highly significant and really kind of, as far as it goes in cardiology, was really kind of a paradigm shift in terms of what we were thinking about and what we sort of used to do intervention. When they carried this analysis out to 2 years, there continues to be a difference in those groups even at 2 years. And for those of you who are health economics people, this is one of the few things that I can think of in interventional cardiology that's dominant, that's you get better outcomes with less money. So these are cheaper, it cost less money to take care of these patients with FFR, and you had better outcomes. So really what we consider a dominant strategy from a cost effectiveness standpoint. And so this is, was really great. And then what happened was, then on the heels of this, they did FAME2, which again looked at lesions that were FFR of less than 0.8. So now they did this, they found a tight lesion, they did an FFR, the FFR was significant, and they said, okay, and then they had a registry group for the patients with normal FFR. And then they said, all right, for the patients with abnormal FFR, we're going to randomize you. You're going to get angioplasty with optimal medical therapy or just optimal medical therapy alone. And this is a lot of the COURAGE trial folks back in the day. I'm sure many of you may or may not be familiar with COURAGE trial. Said that patients with stable coronary disease you can treat medically and they have similar, if not better outcomes than going and getting revascularization. And obviously from the interventional community, that was one of those trials that we hate talking about because everyone wants to talk about it and we don't believe it. But anyway, this is the trial. So this PCI versus optimal medical therapy versus medical therapy. And what happened here, as you could see, that they had 1,220 patients enrolled, and the trial was halted at that point because there was such a difference between the medical therapy group and then the patients who had angioplasty. So there were significantly less events in the revascularization group as compared to medical therapy. And then the primary endpoints in their trial were either death, MI, and urgent revascularization. And when you actually go through and look in the trial and see what were the events that were different, it was really all about urgent revascularization patients. And they did a very, very rigorous analysis of what urgent revascularization meant. Was it just, oh, I have some chest pain? These are people who came in with EKG changes, troponin elevations, being hospitalized, those type of reasons that sort of necessitated this revascularization, because there was a lot of controversy about what urgent revascularization meant. And so this obviously really opened the door and really kind of cemented FFR's place in modern day interventional cardiology. That being said, I think that probably only about 20 or 30% of interventions are done with FFR guidance. And so I think there's still a big lag in the community in terms of incorporating FFR into the interventional practice. And again, I wanted to kind of just make sure that everyone's very clear about what is abnormal. The original work, and you might see this in some older literature, when Nico Peels and the group from Belgium actually first described FFR, they considered less than 0.75 as what was considered functionally significant. And they had this 0.75 to 0.8 was sort of this gray zone. And this is always a very tricky one. When you do an FFR and it was 0.78, as interventional cardiologists, we were always stuck because in the trial, that group had sort of a mixed outcome and they didn't really comment on that. It was sort of like this black box, and so we didn't know what to do with those patients. And then 0.8 was considered not significant. But really based on FAME1 and FAME2, they use this cutoff of less than 0.8 as the cutoff for significant lesion, and that's really what the current standard is. And so that if you are talking to your interventional colleagues, that's really the number that you want to be asking them about. And again, guidelines very similar to the IVUS guidelines. I showed this just to compare with IVUS. That again, there's probably less utilities or less applications for FFR, but certainly to assess intermediate coronary lesions is really what it's there for. And again, the Europeans have a much higher and much more aggressive about this. And I'd be interested to talk to my European colleagues about how often are they doing FFR there. So interestingly, this is the one little piece that I thought would kind of be the fly in the ointment from the surgical perspective of doing FFR, asking all your cardiologists to do FFR on everyone. And this is actually an analysis that these investigators did where they had a large cohort of patients who had multivessel coronary disease who actually all went on to have surgery. They actually looked at them and they had FFR data on all their vessels. And what they did was they used FFR to calculate a syntax score and to talk about severity of disease. And what they found was when you used FFR and considering only FFR, abnormal FFR as an abnormal vessel, they were able to reclassify a lot of the patients. So if you look over here, you have this high syntax score, the low syntax score, and then the middle syntax score here. And so syntax score, the higher the score, the more complex the disease. What happened was when you used FFR to determine how significant your lesions were, you were able to downshift a lot of the disease from people going from 3-vessel disease to 2-vessel disease and 1-vessel disease. And so I'm not sure what that would mean for this community in terms of if we did FFR on everyone, would all of a sudden a lot of our 3-vessel disease CABGs go down to 2-vessel angioplasty cases now. And so that's something to think about. And I just show that as provocative. Again, there's no outcomes data for any of this. And so I think when we presented this at AHA last year, the surgeons in our group were actually, and I think rightfully so, very concerned about doing this because there's really no outcome data to say that this is the right strategy of doing FFR on all vessels and then changing your management approach based on this strategy, because this is just a retrospective analysis. But what they did show that the outcomes actually went pretty similar. If you look at death or MI in these groups, this is what if you use the classic syntax score, but then if you use the functional syntax score, again, those groups in the low and medium risk had, again, continued to have low risk, and the people in the high risk were truly the high risk patients. They really benefited from having bypass surgery. So again, this is one of these emerging concepts. I think they're talking about doing this as a clinical trial, which I think would be actually a very interesting question, and it'll probably be, that's what's actually going to resolve this issue, and I don't think anyone is really clinically doing this or clinically moving patients from angioplasty to surgery based on this. And so then switching gears now and looking at FFR in post-CABG patients, again, like I mentioned earlier, there are no large prospective data sets that have studied the utility of FFR to assess functional significance of lesions and grafts. They were not included in landmark FFR trials. And then again, I think part of the concern is that post-CABG patients possess several features that may impact FFR. Like I mentioned, this potential for competitive flow, and how does FFR handle competitive flow? The presence of collaterals from long occluded vessels, and the possibility of microvascular abnormalities if you have either fibrosis or scarring from prior infarct, how is that going to impact the FFR? And so again, when I read the literature about this, most people think that it's probably pretty reasonable to do an FFR. If you have an abnormal FFR in the middle of a vein graft, it should probably be similar, and the cutoff should be similar. But again, there's not a evidence base to sort of support that. And it's really kind of just empiric what people are doing with that. And again, there's really one study that I found here with just 10 patients, so I really won't even talk about it. But essentially, there's really no correlation between FFR and the severity of stenosis in that 10-patient cohort. And so again, I'll just say that with a grain of salt. And then, is there utility of FFR? And really kind of what we're here today to talk about, and at least what as a cardiologist I can help contribute to this discussion is that, if I could do FFR on my patients prior to sending them to CABG, would that help you, and would that ultimately help our patient? I think that's really the question. I think it's an open question. Certainly there's data here, and the things that we're hearing today sounds like competitive flow is a big issue in terms of graft patency, and thinking about ways to sort of identify that ahead of time may be worthwhile. And this is, again, a patient clearly who's had a bypass who came in with accelerating angina, and you can see, I apologize for the poor angiogram, at least the poor engagement, but you can see clearly the lima is not functioning. And really, there is an LAD lesion there, or a left main lesion there, but it probably is not significant, or it's probably not that tight. There was really there was not an FR done on this patient prior to their bypass. And this, again, I think the disuse or atrophy or string sign really has been described since 1974. And really, when people look at the incidence, it's around, at least from what I've seen in the reports, of around 2% at 13 months. Again, seen primarily with arterial conduits and virtually non-existent with vein grafts. And the etiologies are there's several. I mean, grafting of arterial conduits with a non-critical stenosis sounds like one of the main reasons, and from everything I've read, is the most common. But again, damage during harvest, spasm, and inflammation, or a steal phenomenon. We've seen this a few times where there's a proximal branch of the IMA that didn't get clipped, and then there's a lot of flow going through that branch, and that may be one of the reasons why the lima never matured. But we just theorize, and we really don't know what the answer is. And when you look at competitive flow, again, this is a study that showed that 50,000 patients undergoing CABG, around 2,000 patients who subsequently underwent coronary angiogram, and they found the patency of the lima was high, 93%, 89%, 90%, and 92% up to 15 years. And that's a really great number. There's no stent that's got that kind of number. Again, multivariate analysis demonstrated that really the less severe coronary stenosis was really the risk, independent risk factor for IMA occlusion. But given the overall high patency rate of the IMA, the clinical significance is unclear. And so I think what the authors were suggesting is that even if you have a non-critical lesion in the LAD, really what is your option? What is the clinical option? That's one of the questions I would pose to this audience today is, even if you have this, what are we going to do about that? And I don't really know what the answer is. And here, again, another study where they looked at graft patency, where they looked at 51 to 75% stenosis, 677 patients, CABG patients that underwent coronary angiography, and they really assigned flow patterns into sort of antegrade, competitive, and reversal. And then the multivariate analysis, the grade B and C lesions, as well as these intermediate lesions, predicted graft occlusion. And then they said that really they emphasized the need to prevent grade B or C flow in these flow patterns, which I don't know how you prevent that. And then, blood flow is inversely proportional to resistance, and the resistance in the graft is greater than the native vessel. The distal territory will be supplied by the native vessels. And then I think what was interesting in all this is that resistance over the course of the vein graft is much less pronounced than with IMA grafts, and it's mostly due to this probably the low resistance from the large diameter of these vessels. And when competitive flow is present, diastolic flow in the IMA is lower than in the vein graft. And I think here's the one, there's two studies that I could find in the literature that actually looking at FFR, and I'm going to go through this one relatively quickly here. This is a case series of 105 patients who underwent CABG between 98 and 2000, and then they had angiograms at 28 months, and they had 6 patients who actually had this string sign or the disuse or the atrophic lima. And when they actually looked at what the causes were, you can see a lot of it is a lot of the things that we've heard earlier today, non-significant lesion. And they did FFR on those cases, and they found that the lesion, even after the bypass, they looked and they said these were not significant lesions that were bypassed. Again, the LAD lesions regressed. They had a radial graft that was the source of competitive flow. They had a non-significant LAD lesion as well as a non-ligated proximal branch. And then at one time they did an IMA to a non-diseased diagonal branch, and that was what they hypothesized was the cause for the atrophic IMA. And then use of FFR to predict graft patency. I would have thought that this would have been done in a lot bigger manner, but it's really not been done. This is the only study that I could find. 164 patients undergoing CABG underwent coronary angiography with FFR to all the vessels intended to be bypassed. The surgeon was blinded to the FFR results, and the graft patency was assessed by coronary angiography at 1 year. So this is, I think, getting in the right way of how you're going to need to do this if you want to do this and do it right. So the FFR, again, and this was an older trial, so they considered the less than 0.75 as significant. And what they found was that there was 153 patients that completed the follow-up angiography. 525 of the lesions were initially measured in those patients, and all of those lesions were grafted. As for the FFR measurements pre-CABG, there were 357 lesions out of the 525 that were significant and 168 that were non-significant. And then when you look at at 1 year, what they found is in the functionally significant lesions, 13% of the arterial and 6% of the venous grafts were occluded, or an overall patency of around 91%. And then if you look at the functionally non-significant lesions, you had around a 22% arterial and 20% venous grafts were occluded, or a 78.6 patency rate. So again, this was actually, I thought, a relatively nice trial that they really showed that if you did FFR beforehand and you had these non-significant lesions, that you're going to have a much higher rate of having subsequent graft occlusion. And you can see here a very nice sort of U-shaped graph here that if you have these relatively non-critical lesions, less than 50%, even 50 to 70%, you can see relatively high numbers, and it sort of comes down into the sweet spot when you have this 70% or more lesions. Again, the patency of their lima grafts overall was 93.8%, and the radial conduits was 71%. And so I think, after doing all this, I said there's still this balance between what's research and what's in clinical trial. And when you're sitting in there in the OR and you have a patient's chest open, there's practice, and there's what are you going to do in practice. And I think that's where we have to sort of balance this. And really for all left-sided arteries as well as the PDA, in this study, they said both early and late IMA graft patency is better than vein graft patency. And it really at all levels of clinically important coronary artery stenosis and at all points in time. So they concluded an IMA should always be a more effective graft than saphenous vein for bypassing stenosis in these coronary arteries or their branches. That was a summary, yeah. Cardiologist talking too much, get off the stage. So we're done, last slide. So the conclusion, FFR is a proven tool for assessing the functional significance of coronary stenosis. This is well known and well documented. Again, the FFR of less than 0.8 is considered hemodynamically significant. Use of FFR in post-CABG patients is not well studied, and the competitive flow from non-critical native vessel is the most common cause of IMA graft failure. And preoperative FFR can help surgeons target flow-limiting lesions and may improve graft patency. But I think really it's going to be really helpful to have a clinical trial with some outcomes that really kind of support this. I think if we really want to change practice, and I think, reimburse for this. I think that's really what a lot of this comes down to as well, that it's hard to pay for these things. I think that's exactly the same story for FFR. I think one of the big reasons why only 20 to 30% of the community does FFR, even with this rich data set, is that it's just a cost and it's time, extra time for the physician with really no added reimbursement. So, thank you.